Welcome to ED Debrief, where data meets the gurney. I'm your host, and usually we're here talking about the high-octane stuff, right? Like cracking chests, managing multi-system trauma, or, navigating the chaos of a mass casualty event. We tend to focus on the really noisy, chaotic side of emergency medicine.
Right, the adrenaline-heavy stuff.
Yeah, exactly.
Yeah.
But today, we're stepping away from that noise. We're stepping into a quiet room at the back of the department to discuss a chief complaint that is, unfortunately, incredibly common, massively complex, and requires a completely different set of skills from the emergency provider.
Yeah.
We're doing a deep dive into the clinical and forensic management of sexual assault.
It's a really heavy topic. There's just no getting around that. But it's also one of the most critical things we do. This is one of those rare areas in emergency medicine where the textbook definition of care, it expands significantly.
Right.
It's not just about healing the body anymore. It's about preserving the possibility of justice.
And to guide you, the listener, through this with me, I am joined by our resident expert, an emergency medicine physician who has navigated these exact encounters many, many times. Doctor, thanks so much for being here.
Thank you. It's really a privilege to discuss this. It's a topic we often sort of shy away from because it's uncomfortable, and frankly, it frightens a lot of providers because the stakes are just so incredibly high.
Yeah, you mess up and it's bad.
Exactly. But the data suggests we really can't afford to ignore it.
Let's start right there, setting the scene for everyone. Usually when we talk about the emergency department, the mission is pretty binary, isn't it? Like, is it broken? Fix it. Is it bleeding? Stop it. Is the heart stopped? Restart it. It's very algorithmic.
Very.
But when a patient presents with a chief complaint to sexual assault, that mission changes fundamentally, doesn't it?
It does. It becomes a dual mission. And honestly, those two missions can sometimes feel like they're in direct conflict with each other. On the one hand, you have the traditional medical role, right? Treating physical trauma, preventing infection, preventing pregnancy, and addressing the immediate psychological shock.
That's the part we're trained for, the doctor part.
Right, that's what we are comfortable with. But on the other hand, the ED suddenly becomes a forensic collection site. We are essentially the first link in a legal chain of custody.
Which puts you, the provider, in a really strange position. You're a clinician, but you're also acting as a crime scene investigator in real time.
That is a very fair assessment, and it's a high-wire act. I mean, if we mess up the medical side, the patient suffers physically, they might get an infection or face an unwanted pregnancy. But if we mess up the forensic side, if we break the chain of custody or, contaminate a sample, the patient may never see justice. A rapist could walk free simply because a swab was left on a counter for too long. And we have to do all of that while recognizing the core reality of what has just happened to the human being sitting in front of us.
Right, because this isn't just a car accident. The nature of the trauma is completely different.
Exactly. Sexual assault is defined fundamentally as a crime of violence and power. The intent is to dominate and humiliate. So when that patient walks through our doors, they have just experienced a profound, basically catastrophic loss of control over their own body.
Wow, yeah.
So our job, from the very moment they arrive, is to start giving that control back to them while simultaneously navigating this very rigid forensic protocol.
It's a paradox. Like, I want to give you control, but I also really need you to follow these exact steps for the evidence. Before we get into the how of the exam, the kits, the swabs, the nuclear dyes, and all that, I want to ground us in the scope of this problem, because we see headlines. But the data you shared for this deep dive paints a much broader and, frankly, much more disturbing picture for you and me.
The epidemiology is staggering. If you look at the CDC data and the National Intimate Partner and Sexual Violence Survey in the United States, nearly 1 in 5 women, about 18.3%, report being raped at some point in their lifetime.
1 in 5. I want to pause on that because we hear numbers and we sort of glaze over. That is a massive segment of the population.
Okay.
If you're in a crowded restaurant right now, statistically, multiple women in that room have experienced this.
Correct. It's entirely pervasive. And we cannot ignore the male demographic either. This is a huge blind spot in medicine and in society generally.
I saw those numbers in the outline, yeah.
The estimates for men vary widely in the literature, ranging anywhere from 0.6% to as high as 22.2%, depending on the study and how the question is phrased. But regardless of the exact percentage, it represents millions of men who are often suffering in total silence because the stigma for them is different, but it is just as heavy.
And this brings us to the iceberg concept you highlighted in our sources. What we actually see in the ED is just the tip of that, right?
It is a very small tip of a very large iceberg. The Department of Justice estimates that only about 34.8% of sexual assaults are ever reported to the police.
Wow.
That means nearly two-thirds of these crimes happen completely in the dark. They never reach a courtroom, and sadly, many of them never even reach a doctor's office.
Why is that gap so huge? Is it just the fear of the legal process, or is it something more personal?
It's a complex combination of things, but a lot of it has to do with who the assailant actually is. There's this pervasive myth that we really need to dismantle the stranger in the alley myth.
Right, the guy jumping out of the bushes.
Exactly. We tend to imagine sexual assault as a violent attack by a masked stranger in a dark parking lot, because that's what TV shows us. That's what Law and Order usually portrays. But the data tells a completely different story.
I was looking at the numbers here, and it says only 26% of assailants are strangers.
That's right, only 26%. That means 3/4 of assailants are known to the victim. About 26% are current or former partners, and a whopping 38% are friends or acquaintances.
That is profound. It explains so much about the underreporting, doesn't it? I mean, it's one thing to report a stranger. You have no emotional tie to them. But to report a friend, a boyfriend, or an ex-husband, that is an entirely different psychological hurdle for anyone to jump over.
Precisely. It involves betrayal, the potential blowing up of social circles, family drama. It's messy.
Yeah.
If you report a stranger, you are unequivocally the victim of a crime in everyone's eyes. If you report a friend, you risk being accused of destroying their life. And it also changes the dynamic of the assault itself. Weapons are actually rarely used, only in about 11% of cases. The primary tools of the assailant are force, coercion, and the manipulation of an existing relationship.
So keeping that reality in mind, that the patient likely knows the attacker and is dealing with these really complex emotions of betrayal along with the trauma. Let's walk through the ED doors. A patient arrives. What happens at triage?
Triage is the first critical step. In the ED, we assign acuity levels based on the Emergency Severity Index, or ESI. A heart attack is a level 1 or 2. A stubbed toe is a level 5. Sexual assault needs to be triaged as high priority, almost always a level 2.
Really? Even if they aren't bleeding out, even if
Uh-uh.
their vitals are completely stable?
Yes. This is per Department of Justice recommendations. It's not just because of the psychological trauma, which is severe, but because evidence is degrading by the minute. It is literally disappearing as they sit there. We need to get them out of the waiting room immediately. They need a private room, ideally one that is specifically reserved for these cases, away from the chaos, the noise, and the prying eyes of the rest of the ER.
And I imagine there's some specific instructions given right away that probably sound very strange, even cruel to the patient.
There are, and they are completely counterintuitive for the patient. Think about it. If you've just been assaulted, your immediate instinct is to wash. You want to scrub the event off your body. You want to regain some sense of cleanliness and normalcy. But the triage nurse has to look this patient in the eye and say, please do not shower, do not drink anything, do not rinse your mouth, do not change your clothes.
That has to be heartbreaking to hear. I know you feel dirty, but you have to stay that way for now.
It is incredibly difficult to say and even harder to hear, but we have to explain the why immediately. We are looking for trace evidence, acid phosphatase, which is an enzyme found in high concentrations in semen. We're looking for sperm cells, saliva from bite marks, or kissing.
And all that just washes down the drain.
Exactly. These are easily washed away. If they brush their teeth, we lose oral evidence. If they urinate or wipe, we might lose vital biological material. So we ask them to hold on just for a little while longer to preserve that one chance for justice.
Once they're in the room, who actually takes care of them? I see these acronyms all over the source literature. SANE, SAFE, SART. Let's unpack those for the listener, because it sounds like we aren't just relying on the attending physician who happens to be on duty.
Right. While any physician can do this, the absolute A-team for sexual assault relies on specialized training. The gold standard is a SANE, a sexual assault nurse examiner.
So this isn't just a regular ER nurse who happens to have a free moment.
No, not at all. A SANE is a registered nurse, usually with at least 2 years of general experience, who has gone through rigorous, specialized training. We're talking 40 hours of specific coursework, plus clinical preceptorships. They are experts in forensic collection and trauma-informed care. They know the evidence kit inside and out.
And what about a SAFE?
SAFE stands for Sexual Assault Forensic Examiner. This is a slightly broader term. It can include physicians, physician assistants, or nurses who have completed similar specialized training. The Department of Justice actually established national standards for this back in 2006 to ensure consistency across the board.
And then SART.
That's the Sexual Assault Response Team. That's the multidisciplinary approach. It includes the medical team, so the SANE or SAFE, but it also brings in law enforcement and victim advocates all working together seamlessly.
Why is it so incredibly important to have these specific people? Like, why can't just any doctor do it? I mean, you're a highly trained physician, but you mentioned in the pre-show notes that you strongly prefer a SANE to handle the collection if one is available.
Absolutely, I do. Any doctor can do it, and in many smaller hospitals, emergency physicians like myself do provide this care simply because we are the only option available at 3 a.m. However, the SANE and SAFE professionals are specifically trained to maintain the chain of custody. This is a legal necessity, not just a medical one.
Break that down for us. What does that look like practically?
If I collect a swab, but I leave it on the counter and walk out of the room to take a phone call about another patient, a defense attorney can argue in court that the evidence was tampered with or compromised. The SAN knows how to seal, sign, and lock away every single piece of evidence so it holds up to legal scrutiny.
Oh, I see.
They're also much better at the pacing. As an ER doc, I'm wired for speed. Find the problem, fix the problem, move to the next bed. A forensic exam requires slowness, patience, and meticulous, painstaking detail.
That makes perfect sense. It's about protecting the integrity of the case. So let's move to the interview portion. History taking in medicine is usually rapid fire, right? Where does it hurt? For how long? Does the pain radiate? I assume this interview is very different.
It has to be completely different. The physician's attitude here directly determines the patient's recovery trajectory. If I walk in looking shocked, outraged, or judgmental, I can actually cause what we call secondary victimization. The patient might feel marginalized or even guilty.
So you have to be totally neutral.
The tone must be calm, professional, and endlessly reassuring. We need to normalize their reaction, whatever it happens to be. Some patients are hysterical, some are completely flat and catatonic. Both are very normal physiological and psychological responses to extreme trauma.
And there's a ticking clock hanging over this entire conversation, right?
Yeah.
We are quite literally racing against biology.
We are. We generally operate within a 72-hour window for forensic evidence collection.
Why 72 hours? Like, what magically happens at hour 73?
That timeline is based on the probability of recovering viable DNA or sperm. Sperm motility ceases fairly quickly, but non-motile sperm can be found for a few days. However, the chances of getting a clean, usable DNA profile drop significantly after 72 hours. Now, I have to qualify that. Some states do allow collection up to 96 hours or even longer in certain circumstances, so providers absolutely need to know their local laws. But 72 hours is the general clinical guideline. If it's been a week, we still treat the patient medically, of course. We check for infections, offer counseling, provide medications, but the forensic kit might not be indicated anymore because the evidence is gone.
During this interview, you have to ask some questions that sound, well, frankly, they sound pretty invasive and potentially completely irrelevant to a layperson. For example, the source material mentions asking about consensual intercourse in the last 4 days.
Right. And you can imagine a patient sitting there thinking, why does that matter? I'm here to report a rape. Are you judging my sexual history? But we have to explain the forensic why behind that question.
What?
If the patient had consensual sex with a partner 3 days ago, and we find sperm or DNA during our exam today, we need to be able to distinguish that from the assailant's DNA. It's about not confusing the genetic typing at the crime lab. We need to be able to say to a jury down the line, this DNA matches the consensual partner, but this distinct DNA matches the suspect.
That makes a lot of sense when you put it that way. What about the questions regarding tampon use or douching?
Again, purely forensic reasons. Tampons can absorb trace evidence. Douching can dilute it or wash it away entirely. Knowing if those things happen helps the lab interpret what they find, or maybe more importantly, why they might not find something they expect to see. It helps manage expectations for the case.
And what about the question about alcohol or drug use? I feel like this is a massive trap for many patients. They fear if they admit they were drinking, the doctor will blame them, or the police won't take their assaults seriously.
That is a very valid fear, and we have to address it immediately and empathetically. We ask about alcohol and drugs for two distinct reasons, neither of which has anything to do with moral judgment. First, it directly guides our medical treatment. I might want to prescribe an antibiotic called metronidazole later in the visit.
Right.
If you combine metronidazole with alcohol, it causes a severe, really nasty physical reaction, vomiting, flushing, a racing heart. I need to know if you have alcohol in your system right now so I don't accidentally make you violently ill.
So that's purely a patient safety issue.
Exactly. And the second reason points us toward drug-facilitated assault. If a patient says, I had one single drink and then I completely blacked out, That is a massive red flag for drugs like Rohypnol or GHB. That changes what lab tests I might order. It changes the entire narrative of the assault we are documenting.
That's a crucial distinction for you listening to understand. It's about medical safety and accurate testing, not judgment. So we've done the history. Now we move to the physical and forensic exam itself. This seems to me like the most delicate part of the entire process. The patient has just been violated physically, and now a stranger needs to examine them intimately.
Consent is the absolute key here. And it's so important for patients to know that consent is not an all-or-nothing proposition. A patient can fully consent to medical care, getting antibiotics, getting checked for internal injuries, but they can completely refuse the forensic rape kit. That is their absolute right.
But what if they just aren't sure? Maybe they're too traumatized in that moment to decide if they want to talk to the police or go to court yet. That's a huge decision to make in the middle of a crisis.
That's where the blind kit, sometimes called an anonymous kit, comes into play. This is a vital, vital resource. We can perform the forensic exam, seal all the evidence, and store it at the hospital. Usually for a specific time period mandated by the state, like 6 months or a year, identified only by a barcode or a code number.
Oh, wow. The patient doesn't have to give their name to the police yet. If they decide 3 months from now that they do want to report it, the evidence is safely preserved. If they decide they never want to report it, it's eventually destroyed. It gives them the time to process the trauma without losing the biological evidence. It basically stops the clock from running out. That's incredible. It buys them the time they need to breathe. So moving to the exam itself, how do you document injuries?
We do a very thorough head-to-toe exam. We look carefully for defensive injuries. We find bruises on the backs of the arms in about 32% of patients. We look for scratches on the face, which occur in about 23% of cases. And we document everything using a clock face reference.
A clock face, how does that work?
It's a highly standardized way to map the body, specifically the genital area. Imagine the patient is lying back. The pubic bone is considered 12 o'clock. The left hip area is 3 o'clock. The right hip is 9 o'clock. And the perineum is 6 o'clock.
Okay, I can visualize that.
So if I see a microscopic tear, I don't just say a tear on the left side. I document it precisely as a 1 centimeter laceration at the 4 o'clock position. It ensures that if a forensic expert reviews this file 5 years later in a courtroom, they know exactly to the millimeter where that injury was located.
And I noticed in the notes that you change gloves constantly during this.
Constantly, nonstop. This is entirely to prevent cross-contamination. Think about it. If I touch the patient's thigh where the assailant forcibly grabbed them, and then I touch the genital area, I could physically transfer the assailant's DNA from the leg to the swab.
Which would ruin the case.
It would muddy the waters entirely. Or if I touch the patient's own uninjured skin and then touch a swab, I'm contaminating the sample with my own trace DNA or moving the patient's DNA around. So we change gloves between the general body exam, the genital exam, and the anal exam. It's incredibly tedious, but it is scientifically necessary.
Now, let's get into the CSI stuff, the real forensic technologies. You use something called toluidine blue dye. This sounds exactly like something out of a crime lab show. What actually is it?
This is fascinating science, really. Toluidine blue is a nuclear stain. It has a high chemical affinity for DNA and RNA.
Okay, let's break that down for the listener. Why does a nuclear stain stick to injuries?
Think about the structure of your skin. The very top layer, the stratum corneum, is made entirely of dead keratinized cells. Because they are dead, they don't have nuclei. But underneath that protective top layer are the living cells, and those do have nuclei.
Right.
If there is microtrauma, a tiny scrape or a friction tear that you literally cannot see with the naked eye, that top layer of dead cells is scraped off. The deeper living cells with their nuclei are now exposed to the surface.
So the dye specifically sticks to those exposed nuclei.
Exactly. We apply the blue dye, let it sit for a moment, and then gently wipe it off with a specific lubricant. The healthy, intact skin wipes completely clean because there are no nuclei on the surface for the dye to grab onto. But the injured areas permanently retain the blue dye because it has chemically latched onto those exposed cell nuclei. It essentially creates a deep blue map of the injury.
Does it actually make a big difference in what you find during the exam?
A huge difference. Studies show that relying just on the naked eye, we see genital injuries in about 34% of assault survivors.
Which means you're missing a lot.
Right. But when we use the dye, that detection number jumps to over 50%. That is a massive difference in forensic evidence collection. It's making the invisible visible. It physically validates the patient's story.
That's incredible technology. What about the other tools mentioned, like colposcopy?
Colposcopy is basically using a high-powered, lighted medical microscope to look very closely at the cervix and the vaginal walls for those same microtraumas. And we also heavily rely on a Woods lamp.
That's a UV light, right? Like a black light.
Yes. Biological fluids like semen and saliva can fluoresce or glow under UV light, so we scan the entire body in a darkened room. If we see a glowing spot on the inner thigh or the neck, we know exactly where to swab for the assailant's DNA. It directly guides our collection efforts.
So you collect all these swabs, buccal swabs from the cheek for the patient's own DNA baseline, hair samples pulled from the root, debris, fingernail scrapings, and it all goes into the kit.
Into the kit, placed in specific paper envelopes sealed with tamper-evident tape and signed by me straight across the seal. Then it immediately goes into a locked refrigerator or is handed directly to a law enforcement officer. The chain of custody is sacred. We never leave it unattended on a counter.
Let's talk about what happens in the lab after the kit leaves the hospital. We touched on date rape drugs earlier. I think pop culture has really taught you and me that if you go to the ER, they'll run a quick test for roofies and you'll get an answer in like an hour.
That is a very dangerous and widespread misconception. The standard to tox screen we run in the ED, the one that gives us results in an hour, looks for the big five.
Which are what?
Cocaine, opiates, amphetamines, PCP, and usually marijuana. That standard panel does not look for Rohypnol, which is flunitrazepam, or GHB, which is gamma-hydroxybutyrate.
So if a well-meaning doctor just orders a standard drug screen, they will completely miss it.
100%. They will get a negative result back, and the patient will look at that and think, oh, I guess I wasn't drugged after all. I must have just drunk too much. But they very well might have been drugged. Those specific compounds require specialized send-out tests that have to go to large reference labs.
And how long do those take?
Here's the kicker. The results take days, sometimes weeks to come back. They don't help me treat the patient in the room at that moment at all. They are purely for building legal evidence for the future.
And the timelines are notoriously tight on those specific drugs too, aren't they?
Very tight. GHB is metabolized incredibly fast by the body. It has a very short half-life. It's generally only detectable in urine for about 12 hours. Rohypnol might stick around a bit longer, maybe up to 72 hours. So if a patient waits a day to come in because they are scared or confused, the GHB might already be completely gone from their system. This is exactly why that prompt, high-priority triage we talked about is so vital.
That is a really stark reality check. What about the other routine labs you run?
We run a pregnancy test, either serum or urine, that's vital before we administer certain medications. And we draw baseline blood for HIV, syphilis, and hepatitis B and C.
Why baseline? I mean, why test for HIV right now? You can't detect a brand new infection from last night yet, can you?
Correct, we can't. We test to establish the patient's definitive status before the assault occurred. If the patient tests positive for HIV today, and the assault was last night, we know clinically the assault didn't cause the HIV, they already had it. But if they test negative today, and then test positive in 6 months, we can legally and medically infer the infection resulted directly from the assault. It's entirely about proving causality.
I noticed in the prep materials you didn't mention testing for gonorrhea or chlamydia in those initial ED labs.
Good catch. We actually don't usually test for them in the ED setting for diagnostic purposes. The DNA amplification tests take time to come back, usually a couple of days, and we simply can't risk the patient not following up with us. We can't let them walk out of the hospital untreated.
So what do you do?
We treat empirically. We assume they might have been exposed, and we treat them for everything right then and there.
Which brings us to the prophylaxis cocktail. This sounds like a massive amount of medication to hand someone all at once.
It is. We call it the standard of care prophylaxis. It's a better safe than sorry approach to their physical health. We give ceftriaxone, usually a large intramuscular shot to cover gonorrhea. We give azithromycin pills to cover chlamydia. And we give either metronidazole or tinidazole for trichomoniasis.
And this is where that alcohol warning we discussed earlier comes back into play.
Yes. Let's talk pharmacology for a second because it's important. Metronidazole actively blocks an enzyme in your liver called aldehyde dehydrogenase. This enzyme is responsible for breaking down acetaldehyde, which is a toxic byproduct of alcohol metabolism. If you block the enzyme, that acetaldehyde builds up rapidly in the bloodstream. This causes what we call a disulfiram-like reaction. It's violent nausea, nonstop vomiting, a pounding headache, facial flushing. It feels like the absolute worst hangover of your life, hitting you instantly. We have to be very, very clear with the patient about avoiding alcohol for several days.
Aside from the STIs, we also have to think about hepatitis and HPV.
Yes. If the patient hasn't been previously vaccinated or they aren't sure, we give the first dose of the hepatitis B vaccine right there in the ED. We also offer the HPV vaccine for age-appropriate patients. We really want to cover all the bases before they leave.
And then there's the very heavy issue of pregnancy, emergency contraception, or EC. This is highly time-sensitive, too.
Right. We absolutely want to prevent an unwanted pregnancy if possible. We have a few options to offer. The most common is levonorgestrel, which most people know as Plan B. It's available over the counter, it's easy to take, and has fewer immediate side effects. But, and this is a critical clinical detail, it is significantly less effective in women with a higher body mass index.
That's a major nuance I didn't know. So what is the alternative for a patient with a higher BMI?
We use ulipristal acetate. The brand name is Ella. It's generally more effective across the board and maintains its efficacy much better in patients with higher BMI or obesity issues. It works primarily by delaying ovulation.
Is there a strict time limit on these medications?
The sooner the better. Always. Within 3 days or 72 hours is best. The effectiveness drops off significantly in days 4 and 5. And we always prescribe an anti-nausea medication along with it because if they vomit the pill up, it obviously doesn't work.
I saw a brief mention of the copper IUD in the source text.
Theoretically, inserting a copper IUD is the most effective emergency contraception available, nearly 99% effective. But logistically, it's rarely done in the emergency department setting. It requires a specific sterile procedure, trained gynecological personnel, and the device itself, which many EDs frankly just don't stock. So the oral pills remain the standard of care.
And finally, what seems to be the heaviest hitter in the medication lineup: HIV post-exposure prophylaxis, or PKE. Is this automatic for everyone who comes in?
No, this requires a very serious risk assessment. The drugs used for PP are incredibly strong antiretrovirals, and they have significant side effects: intense nausea, profound fatigue, potential liver issues. We really have to weigh the risk versus the benefit. The biggest factor is the assailant.
How so?
If the assailant is definitively known to be HIV positive, we treat immediately. If their status is unknown, which is usually the case, we look closely at risk factors from the assault itself.
What specific things increase the risk of transmission?
Physical trauma. If there was noticeable bleeding, if there was rectal penetration, or if there's a high viral load in the ejaculate, the risk of transmission goes up exponentially. Rectal tissue is highly vascular and tears very easily, making it a much more efficient route for viral entry than vaginal tissue.
If you do decide to treat, what is the actual regimen?
It's a grueling 28-day course of antivirals. We hit it very hard. Usually a combination pill like Truvada, which is tenofovir and emtricitabine, plus a third agent like raltegravir or dolutegravir. It's a serious physical and mental commitment for the patient.
And the follow-up testing schedule is intense.
Yes. We do the baseline testing, then repeat the blood work at 6 weeks, 3 months, and finally at 6 months. It's a long, dark road of uncertainty for the patient. Imagine waiting 6 full months to know for sure if you have contracted a life-altering virus.
I want to shift gears here to the human element. The source material has a dedicated section on cultural competency and special populations. This seems incredibly relevant to you and me because the reporting rates we discussed vary so wildly across demographics.
Absolutely. Culture impacts absolutely everything we do in medicine: how we perceive trauma, how we express our pain, and ultimately whether we seek help at all. In some cultures, rape is viewed as a permanent stain on the family's honor, or tragically, even as aberrant sexual behavior committed by the victim themselves.
Which is horrifying.
It is. A woman might deeply fear being shunned by her community or blamed by her own family if she reports it.
And what about for undocumented patients? That's a huge barrier.
The fear of deportation is a massive, paralyzing barrier. An undocumented patient might think, if I call the police or go to a government-run hospital, ICE is going to show up and I'll be deported. Providers need to intimately know their state laws regarding this. In many places, you can treat the patient comprehensively and collect all the forensic evidence without immediately involving immigration or even the police, if the patient chooses that route. We have to clearly communicate that safety to them.
Let's talk about male survivors. You mentioned way earlier that up to 22% of men might experience this. But there's a specific physiological myth that causes an immense amount of shame for male victims.
This is undoubtedly one of the most misunderstood aspects of sexual assault. There is a rigid physiological reality that anal penetration or even manual stimulation can cause an involuntary erection or even ejaculation in men.
Even during a violent assault. Even if they're absolutely terrified.
Yes. It is purely a spinal reflex. It involves the parasympathetic nervous system. It has absolutely nothing to do with pleasure or psychological consent. It's purely mechanical.
Wow.
But imagine being a male survivor. You experience this physical response and you think to yourself, did I want this? Did my body just betray me? Does this mean I'm gay? The shame is completely overwhelming.
And I assume judges and juries often make that exact same mistake in court.
They do all the time. Defense attorneys use it, weaponize it. He had an erection, so he must have consented. He must have liked it. That is devastating for the survivor.
So what is the ED provider's vital role there?
As ED providers, we have to educate the patient right there in the room. We have to look them in the eye and say, this was a reflex. It does not mean you wanted it. It does not mean you aren't a victim. That simple medical validation can literally be the start of their healing process. It aggressively deconstructs the shame.
The data from our deep dive also shows that men often have more severe physical injuries.
Right. Yes. Between 40 to 60% of male survivors have noticeable anogenital injuries, which is actually a significantly higher rate than we see in females. This is likely due to the extreme force required and the general lack of lubrication.
And we also need to highlight the LGBTQ plus statistics from the source material before we move on.
The numbers there are alarming. 46% of bisexual women report being raped, compared to 17% of heterosexual women. And for transgender women, 47% report being raped at some point in their lives. These communities are disproportionately targeted by predators.
And they face more hurdles getting care.
Exactly. They often have fewer resources or face outright discrimination when they do seek help. For a trans patient, a physical genital exam can be incredibly dysphoric and traumatic. Using the correct pronouns and being highly sensitive to their gender identity isn't just about being polite. It's an essential component of trauma-informed medical care.
So we've done the exam, collected the evidence, given all medications, and counseled the patient. Now comes the disposition. They actually have to leave the hospital.
This is the critical now what moment. We can't just discharge them to the parking lot like we would someone with a sprained ankle. Safety planning is paramount. Do they actually have a safe place to go tonight? If the assailant was a domestic partner or a roommate, they obviously can't go home.
So you work closely with social work at this stage.
Yes, social workers and victim advocates are heavily involved. We look for emergency shelters or secure friends or family they can stay with. We have to address those immediate physical and logistical needs. We also set up mental health referrals because they are at a very high risk for developing PTSD, severe depression, and substance abuse issues down the line.
Hygiene comes back into play here too. I mean, we made them wait for hours without washing.
Right. Once the evidence is securely collected and sealed, offering them a hot shower, oral care, a fresh toothbrush, that is a massive, tangible step toward restoring their dignity. It's highly symbolic. It's us saying, you can finally wash this off now.
And what about clothing? You took their clothes for the kit.
We often have to take their clothes as vital evidence. We place each item in a separate paper bag. Never, ever plastic, by the way.
Why not plastic?
Because plastic traps moisture and breeds mold, and mold completely destroys DNA evidence. So we use breathable paper bags. But now the patient is sitting there naked. We obviously can't send them home in a thin, drafty hospital gown. Hospitals usually have a dedicated supply of brand new sweatsuits or scrubs specifically for this purpose. It seems like a small detail, but walking out of that hospital in warm, clean, opaque clothes really matters to their psyche.
And there are cultural considerations for clothing too, right?
Yes, definitely. For example, if a Muslim woman normally wears a headscarf, a hijab, and hers was either taken as evidence or ruined during the assault, we need to provide a respectful replacement head covering so she can leave the hospital feeling properly covered and respected according to her beliefs. It's all about restoring their identity.
Doctor, we have covered a massive amount of ground today. From the iceberg of epidemiology to the precise molecular science of nuclear dyes, to the incredibly high-stakes legal intricacies of the chain of custody. If you had to summarize the ultimate mission of this deep dive to the listener, what would it be?
The mission is ultimately balance. We are walking a very thin tightrope. On one side, we have forensic precision, the cold, hard science of blue dye, sterile swabs, and sealed envelopes. On the other side, we have compassionate human medical care prophylaxis, deep counseling, and restoring basic dignity.
Right.
The ED provider has to be excellent at both simultaneously, because if we fail at the science, justice fails. But if we fail at the compassion, the patient fails to heal.
That is a remarkably powerful way to frame it. And as we close out today, is there a final, maybe provocative thought you want to leave our listeners to mull over?
I want us to go back to that iceberg concept we discussed. We spend so much energy, and rightly so, optimizing the clinical care for the 35% of survivors who actually report the crime, and we absolutely should. But I often think about the other 65%.
The ones in the dark.
Yes. The vast majority of sexual assault survivors never see a doctor or a police officer for their trauma. Our medical system is an excellent safety net, but it only catches the people brave enough to walk through the door. The provocative question for society is, how do we create a culture and an environment where that invisible 65% feels safe enough to come out of the dark? Because right now, the vast majority of the suffering is happening in total silence, far outside the walls of our ERs.
A very sobering thought to end on, but an absolutely necessary one. Doctor, thank you so much for your extensive expertise and for walking us through this incredibly difficult but vital topic today.
Thank you for having me. It was an important conversation.
And to our listeners, thanks for joining us on this ED debrief. Keep asking questions.